And Sarah, with all of the challenges that are already surfacing with this switch in reporting, what are the biggest challenges that the NHN took into consideration when deciding and communicating this process?
Yeah, there's three things I want to hit for this question. The first is absolutely the EMR vendor participation, and there's a few things to remember for that. So specifically, first thing that comes to my mind for ECQMs, if one EMR in our entire NHN TIN list for all patients, all payers, if one EMR in that entire list cannot generate the QRDA1, then the TIN level aggregated QRD3 process will result in a failure for everything for ECQMs. So again, ECQMs are very much an all or nothing. And even though we know with the CARES Act that EMRs should have that capability of point and click and generate that QRDA, and it should be a standard output, it has not been point or click. We've known that, or we've heard that from other ACOs who are been trying to vet out CQMs and ECQMs. So with the EMRs, that's a concern. And even to take it a step further, the QRDA file should be a standard output, but like Jordan was saying, each EMR can have their own interpretation of the logic and their own costs associated with that file creation. So for the Nebraska Health Network, we took it a step further and we met up with our state of Nebraska HIE and said, hey, how are you guys approaching this? Like, just trying to understand what our options are across the board. And we confirmed with the HIE that they do not have data feeds in place with all of our TIN clinics today, some of which include a couple of clinics and hospitals right across our state border over in Iowa. So even going the HIE route, when the HIE has that API direct access for QRD3 submission, it's not point or click for them either. So if we look at this from a workload perspective for paying year 2024, we have 25 TINs that are in our MSSP contracts now. Of those, we have 3 direct data feeds already in place, 2 more in the works that'll be wrapped up by the end of 2024. So 5 total. If we were to talk about ECQMs for the ACO, that's 47 TINs with a minimum of 13 different EMRs. And I say minimum because I haven't heard back from everyone yet. And of those EMR lists, that's 13 unique EMR, excuse me, handful of Epic, a handful of Cerner, but like 13 minimum unique across the table there. So I hope this kind of starts to paint a picture of how much of a lift it could be to tackle ECQMs. And when I say ECQMs, what I mean to say is we know that the long-term goal for CMS is to get to electronic reporting. So there is that drive to say to get to that point, but there's a lot of work that has to be done to be able to create those files and do the inputs and the outputs that need to meet those measure specs. So that was one of the biggest things for us, is the EMR vendor participation there. The other major thing I want to call here is those recent healthcare data breaches that have been in the news, because we're asking for a lot of data when it comes to all patients, all payers for non-contracted lives. And that's a huge amount of data that has to be generated, transferred, and stored. And when you think about the difference in the number of lives, like I was mentioning earlier, so web interface, we're talking about reporting on 3,000 folks, Medicare CQMs, again, that was 60,000. But if we were to do all patients, all payers, that's data on 128,000 lives. So there's that piece of it. And then the last thing I want to call here too is the expectations for all patients, all payers now when it comes to working with our specialists, because now going to a specialist and say, hey, make sure you're doing the primary care services for these measures, specifically go to a cardiologist and say, don't forget to do your depression screening and follow-up. I mean, there's a lot of conversations that have to go on at the ACO level to be able to support the all patients, all payers level of reporting.
That's really helpful, Sarah. And just to add a little bit more perspective from what we're hearing from others as well, or what we're even seeing when people are testing out the ECQMs and QRDA1s, is going back to that there's an issue with our results. So for example, if somebody's showing a depression screening of 0%, we know that's not correct. But it's a lot more challenging to get to the root cause for ECQMs than it is for CQMs, which again, we would have the ability to run all the data through our logic within our platform. And very similar to today, you can look through those narratives and figure out what's going on. So I know that's another huge challenge we've run into with the ECQMs as well.